What's going on, guys? Welcome back. Dr. Andrew Fix here on The Code, coming to you with another episode. Very excited to have two rehab professionals jumping on this conversation together, where we're going to get to talk shop for an hour or 45 minutes or however long we have this going. But we're joined today by Dr. Emily Schilling. She is a chiropractor here in town. She relocated to Colorado to specialize and focus on the foot, the ankle, the lower leg, and she's joining us on The Code. She spends time at a practice here called Total Health Solutions, and then also as a provider with another organization called Gait. And we're just like 30 minutes apart here having this podcast. So Emily, thank you so much for joining me on The Code today.
Yeah, thank you for having me.
Absolutely. Absolutely. Well, you guys, to give a little bit of context, at Physio Room, we work with a lot of runners. And here in the Denver area, Emily and her team, they also work with a lot of runners. And there is no shortage of those people here in the Denver area with all the sunshine we have, all the trails and activities we have to do. And we're going to talk about running gait today. And we're going to talk about like all the different injuries and things that we deal with and how we help people manage those and improve those things so that they can run healthy and keep training for their events. But Emily, would you do us a favor and just give a little bit more of a thorough introduction of yourself? Tell us a little bit about you and your background, and then we'll get into it.
Yeah, of course. So, as you said, I'm Emily. I grew up in Wisconsin as a very active little kid. So, I was participating in gymnastics, volleyball, track and field, all the good ones. And over some time, I ended up at UW-Madison, which is University of Wisconsin-Madison. And this is really where I fell in love with the medical field. After a couple of different considerations, a couple different options, I chose chiropractic. And this is when my whole life changed. So I moved from Wisconsin down to Texas. I met my husband, and this is when I really started to get into endurance sports, namely triathlon. And so since that time, I have raced the full Ironman Wisconsin in 2022. I've done a number of halves, a couple of Olympics, and a couple of sprints as well. And I'm very excited that this year in December, we are actually headed to New Zealand for 70.3 Worlds.
Wow.
Yeah, absolutely thrilled. And from being an endurance athlete, this is really where I found my passion for treating endurance athletes.
Mm.
So I've gone on to work with a company called Gait, like you mentioned, which is everything lower extremity, and also in person here at Total Health Solutions up in Lakewood.
Awesome. Awesome. And, anytime we have the opportunity to get another person from Wisconsin that likes endurance sports on the podcast, we're going to take that opportunity. So this will be a fun conversation because you and I have a lot in common. And we've had the opportunity to work a couple events together and sort of get to know one another just a little bit and hopefully more in the future. But glad that we both wound up from Wisconsin, ultimately out here in Colorado. So um, I guess what I would like to start with, and we could take this conversation a number of different ways, but I would imagine that it's similar to my experience. But in your experience, working with runners, working with endurance athletes, specific to the lower extremity, like what are the main issues that you see people coming in the office for or reaching out to you guys, contacting you saying, I am dealing with X, Y, and Z. Can you help me? What are those things that these people are dealing with?
Yeah, so I love that question. And there's a couple of different reasons for why I love that question is three of the common ones that I see are plantar fasciitis, Achilles tendonitis, and then I really like to take some time to chat through stress fractures.
Ooh, yeah.
And the reason I love this question is each of these three diagnoses seem very simple on a surface level.
Mm-hmm.
And you get all the TikToks and Instagrams of if you have plantar fasciitis, do this one thing. And to me, there's so much deeper underneath the surface that, I mean, really needs time to dig into and rehab and get the right treatment. So yeah, those are some of the three that I'd like to chat through. Do you have any preference on which we start with?
Yeah, it's a great question, and I'm right there with you. Well, I sort of say this to people sometimes, like we know from like a research standpoint that runners in particular, the most common thing they deal with is knee pain. But what I often end up finding is that the type of knee pain people are dealing with many times is something that they can kind of continue training through, right? They have it, but it might not be, I like to use the term bad enough to reach out to somebody to like do some treatment to figure out it and fix it. But when we're dealing with these other things, a nasty case of plantar fasciitis, a debilitating case of Achilles tendonitis or tendinopathy, or a dreaded stress fracture. Well, these are things that often you cannot train through or should not train through, especially that stress fracture. And then we end up seeing those people in the office. So like anytime I've ever asked somebody that works at a running store, for example, what's the most common issue people come in complaining about? They always say plantar fasciitis. 100% of the time I've asked that question. And that's not the most common thing runners deal with, but it's one that oftentimes will stop you from running and stop you in your tracks, and runners want to run. So
Yeah, runners can be a little stubborn. Being
mhm.
a runner myself, I am completely aware.
Yeah, so I say we start there. I say we start at the bottom of the foot and go to plantar fasciitis. And when someone comes in to see you, um, how does that process typically unfold? Like, one of the things that I will often say is, people come in saying they have plantar fasciitis, and sometimes it's plantar fasciitis, sometimes it is not. And but it's a very common thing that people are dealing with and struggling with. And I'm with you. We see on Instagram or wherever else, do this one thing to fix it. And you and I know it's not a one size fits all approach, or one thing is not going to fix the problem. So how does that process normally look, and how do we go about fixing this?
Yeah, so in our office, all of our appointments for new patients are an hour and a half. And so that's where we want to know everything from
Mm-hmm.
biomechanics to how you're running, how you're loading, what range of motion looks like, history, all of that good stuff to form the whole background, form that whole picture of what in fact we are dealing with. Because, like you mentioned, Google, wonderful resource. But for a number of people, if we Google symptoms of heel pain, plantar fasciitis is one of those common things that pops up. And so it can be kind of challenging when patients come in saying, oh, I have plantar fasciitis, and knowing, yes, you still have to do your due diligence, take a look into it, make sure it is in fact plantar fasciitis, and then treat that appropriately. But yeah, in our office, a huge part of it is education, and
Mm-hmm.
not only what plantar fasciitis is, but how to go about rehabbing that so that then they have those tools.
Mm-hmm.
Yeah.
Now, let's maybe take this from like a general sense. Obviously, each person has their unique things that they're dealing with, and some may have plantar fasciitis, some may be dealing with a tendon issue or a joint issue in the foot. But say someone does have plantar fasciitis, as a very general rule, like, what are the types of things that you find yourself doing with those clients in the office to help them rectify that situation? And I guess I'll preface this by saying many times what we'll see online is roll your foot on a frozen water bottle. Wear this night sock that stretches your toe back and stretches the bottom of your foot. Roll your foot on a lacrosse ball. And it's these passive symptom management style things. What do you find actually doing with people that you feel like is really helping them fix it and get past it?
Yeah. So that's where we can get into a little bit more of the two different types, the two different foot types that both have plantar fasciitis. So we
Yeah,
have
let's
both,
talk about that.
yeah, the low arch or the flatter foot, and then we have a really high arch or more of that rounded foot. So both of these can present with plantar fasciitis, but both are going to have very different treatment plans. And
Mm,
so this is where if we have a lower arch, a flatter foot, I like to relate it to if we have a bed frame and we have a mattress on top. Our bed frame is our plantar fascia, and our mattress typically is a muscle called our flexor digitorum brevis.
mm-hmm.
If this muscle, that mattress, is not great, and we have some kids jumping on the bed, that bed frame is going to get torn up. Our poor plantar fascia, if that muscle isn't doing its job, he's going to get so much work, so much load put through it.
Mm-hmm.
So, to demonstrate this a little bit clearer, if this is the bottom of my foot, My plantar fascia starts up by the toes, comes down and attaches onto the heel,
Hmm.
our calcaneus. The flexor digitorum brevis also starts up at the toes, runs down, and also
Yeah.
attaches onto this calcaneus. And so when we talk about the plantar fascia, we really have to talk about the flexor digitorum brevis.
Yeah.
Flexor digitorum brevis should be the muscle that is helping to hold that foot shape and absorb a lot of that shock.
Hmm.
And so this is one of the huge muscles that when we have lower arched individuals, we spend a lot of time working on. And the last little piece of this is we have flexor digitorum brevis, which comes down and attaches onto the heel. We also have flexor digitorum longus, which
Hmm.
starts up at the end of the toes and then goes all the way up.
Yeah.
Longus is the muscle that we use for towel scrunches or marble pickups.
Yeah.
Great exercise, but typically people are really strong in this muscle. And so this is where targeting flexor digitorum brevis
Hmm.
is going to be a wonderful one to help offload that plantar fascia,
Yeah. And for
especially
those,
individuals.
yeah, sorry to interrupt you. For those of you guys that are listening in, this episode will be on YouTube. So if you tune into our Physio Room YouTube page, there's a playlist with all of the Code Podcast episodes. And what Emily was just showing us was a skeleton model of the foot and sort of like laying out the landmarks where the plantar fascia attaches, where this muscle, the flexor digitorum brevis, attaches. And basically what she's saying, right, is that muscle supports the foot, supports the arch, provides the toes with a lot of their strength and their ability to have stability. And when that muscle is not doing its job, the plantar fascia is going to have to play the pickup role to then it's going to take a lot of load if that muscle is not doing its job. Um, Emily, in order of like layers of superficial and deep, what is deeper to what with the flexor digitorum brevis and the plantar fascia, just so people can wrap their head around picturing this in the foot. And I liked your bed frame analogy.
Yeah, it's one of my favorites. It's actually a patient brought that up and was like, yeah, this feels like a good example. Absolutely loved
It's
it.
great. Yeah.
Yeah. And so when we talk about layers of the foot, and not to get too much into it, but we do have those four different layers. There are so many muscles and pieces of the foot.
Hmm.
And this is why we can have a bunch of different foot pains, and it's so important to be able to differentiate. And so this is where, yeah, we do have that plantar fascia running along the outside, and we have that flexor digitorum brevis sitting one layer inside.
Yeah. A little deeper. So the plantar fascia is on the bottom of the flexor digitorum brevis. Yeah, I love that. So that's particularly relevant when, from a stability standpoint and supporting the bottom of the foot when we have that individual that does have a little bit more of a flexible, flatter foot and that lower arch type. How does that differ when we have that person that has the higher arched foot that's a little bit more rounded?
Yeah, so when people have a higher arch, typically it means it's going to be a little bit more rigid. And so this is where shock absorption is a huge part of this. If I hold my hand like this and I bounce it, there is a lot of force going from one hand into the other. If I'm able to flatten that out, it's not as stiff, there's not as much force going through this structure,
Hmm.
typical to that higher arch. And this is again where that plantar fascia gets a lot of work that is not in its job description, and it gets angry and it says, I've been doing too much for too long. And this is when we get pain because it's saying,
Hmm.
red flag, I can't do this anymore. When we have a higher arch, as opposed to working a lot on strength and stability, we really need to shift that mindset and think, okay, there's already a fair amount of strength, there's already a fair amount of rigidity. How can we kind of calm the system down?
Hmm.
And so this is where it kills me a little bit of everyone thinks that a flatter foot is awful, is a
Yeah.
thing that you want to avoid at all costs. A flatter foot is our shock absorber. And so this is where with a higher arch, I'm not trying to turn you into a flat foot individual. We want access to that whole range of motion.
Hmm. Hmm.
With people with higher arches, if this is my foot, we want to work on being able to flatten that foot for that shock absorption, as opposed to just having that rigid arch.
Yeah, I think that part that you just walked right into there, that piece of the conversation is a very important one to have, because I think I'm starting to see this trend change a little bit with, I think a little bit better education of, we're going to running stores, we're hearing the individuals that are recommending shoes to people. I think they're doing a great job compared to conversations I've heard years ago, where I feel like years ago, the conversation was always, we need to control as much motion at the foot as possible. And, it would be someone at a store watching someone walk or run on a treadmill. And if there was any amount of pronation, they were trying to like stop that from happening, right? And pronation being that rolling of the foot inward towards the medial side, towards the big toe, quote unquote flattening of the arch, right? Which is a necessary thing for shock absorption, for using our full range of motion. Like Emily just said, we are supposed to pronate. And if you don't, and you have one of these more rigid foot types and your arch does not flatten, you can wind up with a lot of issues too that may be the same or maybe different than the person that is way too much on the other end of the spectrum and way too flat. And if they can't display an arch. So we need to have access to both. And I think access is a good word. Like, we need to be able to display an arch. We also need to be able to let that arch move and flatten to go through the natural direction of the foot. And, I'm actually one of those people where I don't know if I'd say I fall in the middle, but I have an arch that I can definitely work through a range of motion. I can keep it nice and firm when I need to, if I'm like, say, lifting weights or something. I also can flatten it out if I need to. And then there have been times in my life where I have worn orthotics, and I think that has caused me more problems than solutions, because it didn't allow me to let that arch flatten out, absorb the shock through my foot, through my ankle, and I've felt more stress farther up the chain, knee pain, back pain. And when I took those orthotics out, those issues went away. So having access to that is so important. And I think if you look down at your feet as you're doing this, or go walk around barefoot, like, what type of foot do you think you have, and how do you fall in this spectrum? Do you fall on more of the low arch side or the higher arch side? And think about if you've dealt with some of these things.
Oh,
So, okay, so Emily, so we have the distinction between, we've got the lower arch, we've got the higher arch. Both of those people could be dealing with heel pain, maybe plantar fasciitis. And the one approach tends to be more of a stabilization based thing. The other approach tends to be more of a, how do we get more motion? How do we let that arch um, flatten and let those muscles lengthen out to provide some shock absorption, so that we're not hitting into such a rigid piece of the body. How does this, since I just brought up orthotics, like, how does this conversation then lean into orthotics and shoes, and like, what should people be putting on their feet relative to what type of foot that they have?
yeah. And so I mean, the shoe question is an absolutely fascinating question. Uh, and there's so much to consider because, like you mentioned, everyone's foot is different and needs different things depending on strength, stability, and all these number of factors. My general rule of thumb with choosing a shoe is trying to have a couple of different options that we can go to. So this is where, for the everyday runs, for the longer runs, having a shoe with a little bit more cushion, that's going to be your workhorse. So that's the shoe that will be your go-to. We have a little bit of stability in there. We have some cushion. Foot is very comfortable for those longer distances and for those everyday runs.
Mm-hmm.
The second shoe that I really love to have is one that is very low cushion. And the reason why is because in a low cushion shoe, our brain is able to feel what's happening under the foot. And so this is where brains work on patterns.
Mm-hmm.
So we don't have to think when we run, for example, right? Our foot goes out in front of us and our next foot goes out in front of us, and we just keep going back and forth. We don't have to think, okay, extend the leg, set down the heel. Okay, now roll through the, we just do the thing. And so this is where changing those run patterns can be very difficult. It's something that takes a lot of different exercises, a lot of different cues, a lot of different subtle hints to get
Yep.
someone to change their run form. The wonderful, absolutely wonderful thing about that low cushion shoe is it gives your brain more information. So if we're landing really heavy on our foot, the brain's going to say, "No, I don't like that. That's not comfortable. That's not good.
Yep.
How can I how can I tweak this? How can I not land as heavy on my foot?" And brain will automatically make some of those changes because it's
Yep.
actually able to feel what's going on.
Hmm.
And so that's where we don't use our low, typically, we don't use our low cushion shoe for long distances or for everyday runs, but using it for some of those lower mileage, a mile or two every week can be awesome feedback and promote some of those nice little subtle changes.
Hmm.
It's a lot more injury free.
Yeah.
And yeah.
Yeah, I love that.
And
And I mean, basically what you're describing is we are changing the input that the person's receiving by changing the footwear or whatever is underneath their foot, right? And I think probably everybody listening to this, even if you're not a runner, you can relate to this by like if you go walk barefoot on the grass or a softer surface compared to walking barefoot on a hard wooden floor, a tile floor, cement, you're going to walk differently, right? On those harder surfaces, you are not going to feel comfortable slamming your heel into the ground when you're walking because your brain is going to be receiving that input and it's going to say, hey, that doesn't feel good. Let me take shorter steps. Let me take softer steps. Let me land a little more forward on my foot instead of the back of my heel jamming into this pavement. And the same thing happens with the shoes, right? If we have a more cushioned shoe, our body, our foot doesn't have the ability to receive that input quite as well. And like Emily just said, our brain gets in a pattern, or many people will use the frame or the phrase like muscle memory or something. It's not just muscles, it's other things too. But we get in this pattern of like we're so used to doing something one way that if we don't change some of the pieces that allow us to get different inputs, the output's going to be really hard to change, right? So, and like she said, we will often in the clinic implement a lot of different cues and things, and sometimes those work really well for people and sometimes they don't. Sometimes just changing the footwear that they're doing is a great cue that just allows their body to figure it out. And yeah, I love that idea. So maybe if someone was going to wear that lower cushion shoe, they're probably using that for like a lower mileage tempo day, maybe a speed work day that has some intervals mixed in, but not probably their long run on the weekend or something like that.
yeah, and I should definitely preface this of if you are typically running in a high cushion shoe, trying to go directly to a low cushion shoe that doesn't give you much, it is a process, and it's a very worth it process, but it's something where we don't want to jump from high cushion to no cushion
Hmm.
without any sort of transition. And so that's where, depending on how much you're running, starting with even a quarter of a mile, half a mile, and then doing a small loop,
Hmm.
circling back home, grabbing your medium
Yeah.
high cushion shoes, and finishing out the rest of that run is a perfect way to start integrating your way into that low cushion shoe.
Yeah.
Because your foot is going to have to do more work.
Yep.
And so that's where people who are starting to transition into the low cushion shoe, if your foot gets fatigued, that's okay. Muscles are working, your foot is building that strength,
Hmm.
building those different patterns. That's awesome. But that does tell me, yeah, okay, let's keep it slow. Let's ease into this until we have those muscles, those patterns to be able to use it on, like I said, a mile or two
Yeah.
low mileage run.
Yeah, I think like you're saying to us, it's expected that that person's going to have some, I don't know, I don't want to say growing pains, but some little discomforts and some soreness potentially in the muscles of the foot because like you said, the foot's going to have to work harder to take some of that support and structure away. And I like what you said about use that at the beginning of your run, like use that for the beginning of your run and then swing back to your house or your car, change into your other shoes if you're planning on doing many more miles that day so that you're using it when you're fresh before the body gets really fatigued. Because if you did this the other way around, and you're running and you get to the last mile of your run and then you switch shoes to the one that provides you less structure, you may already be a bit fatigued. And then that's going to be even more demand on the system. And when we're trying to make these changes like incrementally, we're trying to prevent people from getting injured, right? And doing that at the beginning of the run is an easier way to slowly make that transition while minimizing the risk of somebody getting hurt. And I think running in particular, people have probably heard of this like 10% rule. And, when we're building up somebody's volume, somebody's running mileage per week, we talk about the 10% rule of like increasing your volume from one week to the next by approximately 10% week over week. When somebody switches to a less structured shoe or a lower drop shoe or something like that, I kind of like to try to implement the same principle. Like, okay, take your total running volume for the week. I only want you doing about 10% of that in this shoe, the new one to start with. And then with that shoe, we can implement the 10% rule and gradually build it up. Basically, the same thing that you're saying, slowly increase the amount of time you spend in that shoe and don't try and just go cold turkey. Otherwise, you'll probably wind up in one of our offices helping you fix that.
Oh, definitely.
Well, what I'd love to do, Emily, is let's stay on the topic of shoes for a minute because this is relevant to all the issues we are talking about: plantar fasciitis, Achilles, stress fractures, and everyone listening to this is doing activity in shoes. Let's just define a couple things first, and then we'll talk about what types of shoes do you normally recommend to clients and why. But when we talk about shoes, you mentioned we have higher cushioned ones, we have lower cushioned ones. Can we go through and define a couple terms? Like when we're talking about a shoe, what does it mean to have a neutral shoe versus a stability shoe? What is the difference between the stack height of a shoe compared to the drop, the heel to toe drop of a shoe? And let's go through that, and then we'll start talking about what we recommend and why.
Yeah, yeah. So I have a couple different shoes here with me to chat through.
Perfect.
So the first one we can chat through is going to be stack height.
Mm-hmm.
And so this is where typically this is measured in millimeters. When you see on a website, it'll say stack height and it'll say anywhere from, well, 0 to typically mid 30s stack height.
Yeah.
And so if we look at a pair of shoes, that's the cushion that we see under that shoe. And this is where there's a new style of bringing the foam really high up on the back of the shoe. This doesn't necessarily mean that your stack height is going to be that entire top of the foam piece. It's just whatever is under that
Mm-hmm.
shoe. And this plays into heel drop. So we have a certain amount of cushion under the back of the shoe, and we have a certain amount of cushion under the front of the shoe. If these are even levels, this is a zero drop shoe.
Mm-hmm.
If we have a shoe where there's a lot more stack under the heel than there is under the toe, this would be a heel drop. So
Yeah.
there's more stack at the heel, less stack at the toe.
Yeah.
E,
No. Oh, go ahead. Sorry.
no, it's all good. And one of the things that this plays into, and this is important for race shoes, and then some of those other diagnoses in terms of if our big toe can't move, is going to be heel and toe rocker. And so this
Mm-hmm.
is where if I have a high toe rocker, when I push on the tip of the shoe, there's a lot of movement here versus something like this guy. When I push on the toe, there's not there's not a ton happening. Similar on the heel, we can also have those heel rockers. And these are different ways that the shoe can be made in order to accommodate different necessities of what's needed.
Yeah. So with those, like with those different rockers, if you have somebody coming in the office and they have particular challenges, particular symptoms and issues that they're dealing with, you may recommend to them a different shoe, potentially for like, forever or potentially for a short time while you work on some of these issues to help them mitigate some of these symptoms that they're dealing with to continue being active in their sport.
Yeah, because runners are
Mm.
going to run. We
Yeah.
just try to make them as comfortable as possible.
Yeah, totally, totally. Now, I guess you just showed us a couple different types of shoes there, one with a zero drop, one with a few millimeters drop, and a couple different brands. But generally speaking, what types of shoes do you find yourself recommending to clients, and why do you tend to deviate that way?
Yeah, so something that we really like in shoes is it being foot shaped. And so this is where one of the brands that my foot works really well in is the Ultra. And so if I take out this insole, as we can see, we have this whole shape of the toes. And so this is where most people's feet are going to be the widest, is that toe section. And so
Mhm.
this is where some shoe companies drive me a little wild in that they'll say, this is a wide shoe. And when they refer to that wide part of the shoe, typically they're referring to the midfoot, so that middle of the shoe.
Mhm.
Typically they're not referring to the toe box. And so this is for people who do have that wider forefoot, that wider toes and up. Having a wide toe box can be so much more comfortable and so important for movement efficiency and all those things.
Yeah.
Um, so yeah, ultras work really well for me. I
Mhm.
like that it's foot shaped and they are typically a brand that we recommend fairly often in our office.
Yeah, we find ourselves doing the same thing, and I know you have at least one pair of these too. In addition to Ultra, another brand that I really like is Topo or Topo Athletic, for the
Yeah,
exact same reasons that you just mentioned. They have that wider foot-shaped toe box of the shoe, and then both of these brands have options now that range from the zero drop up to like a 5 millimeter drop shoe. So I think what you'll find, whether you're talking to Emily or someone on her team or talking to myself or someone on our team, the things we're going to prioritize in a shoe is that it's comfortable for the person. It has a wide enough toe box for that individual. Like if you're me and you look down at my feet, I have a wide toe box, right? And it narrows, my foot narrows back towards the heel. Other people, I had someone in the office yesterday, she has a fairly narrow foot. Her foot is like the exact same width the whole way through. And maybe the same shoe for me would not be the right recommendation for her. But we want to make sure your foot fits on the insole of that shoe, because if it doesn't, and that's the whole bottom section of the inside of the shoe that your foot is standing on, and you're hanging way over that, that means you're pushing out, or conversely, the shoe is pushing in. The upper portion of the shoe is pushing in on your foot, your toes, squeezing things in. And what we know is if your foot can't splay, your toes can't spread, and you can't use them similarly to how you would use them without shoes on, you're going to negate some of the mechanisms in the foot that help propel us forward, help create stability and rigidity to support us when we're moving around.
yeah, yeah, and that's well, such a deep topic of
Oh yeah.
rabbit holes to go down. Um, but yeah, having the room to use those toes of when we talk about flexor digitorum brevis back with plantar fasciitis, if I squeeze all my toes together and try to push them down, there's not a lot of surface area. There's not a lot of push.
Mm-hmm.
If I'm able to spread those toes out, there is so much more power under this foot. And so even when you talk about sprinting, going fast, or having that muscle endurance at the end of a marathon,
Mm-hmm.
the ability to use all those wonderful muscles for a strong push off to propel us forward is so important.
Totally. Totally. Well, speaking of propulsion and our ability to move forward and have the mechanisms able to do that, let's shift gears a little bit to the Achilles tendon. Because what we know is the Achilles being the largest, strongest tendon that we have in our body, it can really do a lot for us to store some energy, propel us forward, help us be able to run, sprint, jump, and absorb things. But if we're having issues with it, man, it can cause us a lot of locomotion challenges as well. And there's probably not a part of my body that I have felt more limited from compared to the Achilles tendon when I've had issues with my right Achilles. It impacts basically all the activities that I want to do because most of those are lower body based, right? It's not swimming. So, um, tell us about the Achilles a little bit and what are the common issues that you tend to see with people coming in when they're complaining of their Achilles, and then how do we go about approaching this compared to the plantar side of things?
Yeah, so to start off at a little bit more of a base level, our Achilles, that tendon at the back of our ankle, is made up of two huge muscle groups. So if we feel our calf, on that outside, we have a muscle called our gastroc. And one muscle inside that is a muscle called our soleus. These two muscles come down, do a twist, and that's what forms our Achilles tendon. And actually, it's our soleus that forms 2/3 of that Achilles. So when we talk about Achilles, we can't just focus on gastroc. We also have to take some time to consider soleus and how that is handling that load.
Yeah.
But in general, for the Achilles, there's three different types of Achilles tendonitis, and there's two main ones that we'll take some time to chat through. So we have non-insertional Achilles tendonitis, and we have insertional Achilles tendonitis. And so, as these two names imply, one, we have pain where it inserts, which is insertional, and then we have pain in that tendon belly, so not where it inserts or non-insertional.
Hmm.
And so the there's a huge differentiation in terms of the things we want to do for rehab between these two. And so again, this is where you see Achilles tendonitis do a crap ton of heel raises, and that's the magic bullet. That's what's going to help everything. Stretch your Achilles a ton, it'll feel great.
Hmm.
So differentiation between these two. For insertional, or where it inserts,
Hey, Emily,
it,
can you grab that foot model that you have next to you, and just show everybody that's watching us on YouTube, where does that Achilles tendon insert on the calcaneus on the heel?
yeah, so we talk about the whole back of the heel is a bone called our calcaneus. And so all back here is our insertion for that Achilles tendon. And so this is where if we have pain on the heel or near that insertion, this is going to be insertional. Versus if we have pain somewhere above there, this
Hmm.
is going to be that non-insertional. So yeah, with the insertional Achilles tendonitis, because it's inserting, if I stretch that area, tendon is not going to be happy. Tendon is
Hmm.
going to be having a bad time. And so this is where we also get a lot of people that do heel raises on a step. Again, this is stretching that Achilles. This is not going to feel good. We don't want to stretch insertional Achilles tendonitis. We are simply going to cause a little bit more pain and even a little bit more irritation at that insertional area. We do want to start to load it, but no off the step, no heel drop calf raises.
Hmm.
And so this is insertional Achilles tendonitis. Non-insertional Achilles tendonitis, so that muscle belly or that tendon belly, pain up here, eccentrics are going to be the key. And so this is, we can concentric, make it shorter. Eccentric is going to be that slow lengthening of tendon, muscle, whatever we're referring to.
Hmm.
So this is where we'll typically go to the top of the calf raise, slowly come down, and that is going to be that eccentric motion. Nice thing about the non-insertional is these typically respond a fair amount faster than the insertional. But yeah, that's a brief overview over insertional versus non-insertional.
Yeah, I like that. And it's an easy distinction to make, right? Like, is your Achilles pain right on the back of the heel, or is it above the heel in where you truly see the Achilles, the heel cord? And then what do you find is most common that you have people coming in for, that insertional pain or the non-insertional pain that's a little higher?
Yeah, and so actually I find this to be fairly 50-50.
Hmm.
And and that's where there's a number of different things that can lead to the two different types.
Yeah.
But something that can really make insertional Achilles tendonitis mad is if we get a pair of shoes that rubs on that area where it inserts. Achilles is not going to enjoy that, and that's where we can start getting some of that inflammation. And so when we talk about shoes in general, apart from just slow transition into low cushion shoes, slow transition into a new pair of shoes is
Hmm.
really important to give the body time to adapt. And so yeah, even with insertional Achilles tendonitis, some of that can be caused from rubbing on the shoe. We want to make sure to ease into our shoes.
Yeah. Yeah, that's one of the things I think that I look for the most for myself in a pair of shoes is one that really feels secure and locked around the heel. I remember when I was younger, um, I was so particular about my shoes when I was a kid, and I had to, now I've gone a little bit away from this now, fortunately, but I had to have them tied so tightly because I did not want my foot like moving around in the shoe, like sliding around. Now, in my career and adult life here, it's very important to have a shoe that your foot can move in, right? We talked about the toe splay and everything. But like Emily just said, we don't want a shoe where our heel is just like sliding around and rubbing, producing friction on the back of that heel, let alone you could cause blisters and things, but it can irritate the things underneath the skin, the bursa on the back of the calcaneus, the Achilles tendon attachment, and yeah, it can definitely be a big factor.
Yeah.
Question for you. We talked briefly about the what the drop of the shoe is, the difference in height between the heel and the front of the foot. Just like we talked about with plantar fascia and plantar fasciitis and having like online, people will find these symptomatic one fix type of things, roll your foot on a ball or a frozen bottle, stretch your foot. We see the same thing with the Achilles a lot of times. And you mentioned like people will get told, just stretch your calf and do heel raises and you'll be fine. One of the other air quotes again, solutions that I often see people going with or telling me in the office is that they were told by somebody just to get a shoe that has a higher drop and just wear that and that'll take some stress off your Achilles and you'll be fine. How do you find yourself implementing possibly a higher drop shoe with people? And can you tell us a little bit about like why just switching to a higher drop shoe is probably not the solution for everybody long term to fix this problem?
Yeah. And so this is where a huge part of this depends on what the person's goals are. And so, for example, if someone comes in and they have a 100-mile race and I have 4 weeks to treat them,
Yeah.
we
Which
are
is
going
always the case, right? It's like, I have a race in a couple weeks. This has been bothering me for months. Can you help me get to the starting line of the race?
to, easy, easy. Yeah, yeah, yeah. We'll just tap our magic wand and everything will be wonderful.
Magic.
Yeah, and so this is where with people that do have these big goals coming up very quickly, we are going to go very aggressive in terms of what we recommend, rehab. I mean, anything we can do to get them to that start line.
Yeah.
And so this is where that heel to toe drop, a higher heel to toe drop, is going to offload that Achilles. It's not going to have to work as hard. Typically, there will be less pain with this motion. So if I have someone that needs to get to the start line, heel to toe drop is very nice in the moment to say, okay, Achilles, we're going to take some of that load off. You don't have to do as much. Go ahead and finish the race. And then afterwards, we hit it hard with
Hmm.
looking at which type of tendinopathy we're dealing with, getting that exercise regimen, working through those things so then we can transition back to typically more of a zero drop or a low millimeter drop shoe
Hmm.
to where the Achilles has to do that work again and has to
Yeah.
stay strong.
Yeah. And that's the thing, has to stay strong because, I mean, I'll tell you with myself, having had Achilles tendinopathy problems for many years, which quite frankly, I developed this after long before I knew the things that I know now, but I developed this after an ankle surgery coming out of a boot, or excuse me, a cast and then a boot, where I had lost a lot of mobility and range of motion in my ankle and in the soft tissue. And then, again, like I said, I didn't know the things then that I know now. I was not really directed down a path to fully rehabilitate that and gain those things back. I was pretty much told, yeah, just start to go back to activity. And if you don't have pain, you're good. And I started to get back to things relatively quickly. And I developed my very first case of Achilles tendonitis. And, not really realizing at the time that I had such a big mobility difference between my two sides. But with almost every client that I've ever had the opportunity to work with, it is not the stretching that makes that tendon get better. It's the strengthening and all the other things, the activity modifications and things while we back them back down, build them back up to a place where they want to be. Because we know that that tendon needs to be really strong in order to tolerate the things that we want to do, whether that's walking, running, jumping, and stretching isn't going to provide you with that strength to be able to do those things. So those stretching may be a component of the rehab plan. I'm sure Emily and I would both agree that if we had to pick strengthening over stretching, stretching is going to be out the window, and we're going to strengthen through a range of motion 7 days out of the week, every time with all the clients we work with.
Yeah, yeah, because it's something that I see very frequently is people with any sort of tendonitis, they come in and they tell me, yeah, I started to get some pain in X, Y, and Z area. I decided to take some time off from running, some time off from exercising. And after 3 or 4 weeks, I started to build back into it. Things felt good. And after some build, things hurt again. And
Mm-hmm.
every once in a while, I hear people say, and so then I took 3 to 4 weeks off again. I figured just a little bit more time rest, and then everything will be good. And the thing about tendons is they need load. So giving them that load and or building that strength is really going to be the thing that gets them better.
Yeah.
Rest, we're not going to touch tendons at all.
Yeah.
Stretching, very useful component, but it's not going to be the thing that fixes the problem.
Yeah. Yeah. And sometimes, I would say maybe more than sometimes, oftentimes, implementing some loading actually will help minimize people's symptoms, right? It will help them feel better, even though, that's not necessarily the train of thought people are having oftentimes before they wind up in our offices. Um, but we just had this yesterday where I had a woman in here and we started loading something and her pain got better in the session. And you could just see on her face this realization of like, okay, great. I can work this and it can get better. I don't just have to rest, like you said, because with these muscle and tendon things, rest is not going to solve the issue. Now, there are times where we do have to reduce the activity level that people are doing sometimes and implement a little bit of rest and recovery. But I would tell you much more often, we are trying to keep people doing as much as they can while we work on the things. Because, like you said, runners are going to run and we don't want to tell them to stop unless we really feel like we have to.
Which is actually a perfect segue into stress fractures.
There you
Yeah.
go. Boom. It's like we've done this before. So let's talk about stress fractures and pretty much the one situation where we do have to tell people, I need you to stop running. I know you don't want to, but I think this may be a stress fracture. We know these can happen in a variety of areas, but tell us what you tend to see in terms of stress reactions, stress fractures, people coming in with these types of symptoms and how we manage that.
Yeah. So, like you mentioned right off the bat, stress fractures are not something to mess around with. This is the one time where we say, don't run. You are not allowed to run. We're not doing any sort of loading through that foot.
Mm-hmm.
And so, typically with these people, we'll see red around the area of pain. It'll be a little swollen. And then that pain will be very pinpoint to where it's not yeah, it hurts somewhere in this region. It'll be it hurts here, right under my finger. And with this, a pain on the top of the foot is a little bit more indicative of a stress fracture, depending on where it is, than pain on the bottom of the foot. We don't have nearly as much on the top of the foot. So when something red, swollen, pinpoint pain on the top of the foot, that is definitely something that we pay very close attention to. And it's actually fascinating, even in stress fractures, there's a huge differentiation between types of stress fractures.
Yeah.
This is where we can have shock stress fractures, and we can also have instability stress fractures. So, to chat through this a little bit, and this is I love all of this. So let me know if I'm taking this a little bit too deep, and we could always bring it back.
No, yeah, I think where you're probably going is great. So let's dive into it.
Awesome, awesome, awesome. Yeah. So we've talked a little bit about that calcaneus. If I'm a runner and I'm landing on my heel, if we keep running and we keep adding a lot of load through this heel, that can be a lot of impact. This is going to be a shock type stress fracture. It's direct impact.
Yep.
Similarly, we have this is our little pinky toe sitting out here. We also have people that land very heavily on the outside of the foot. And again, we can get that shock type stress fracture
Hmm.
happening out at that fifth digit. On the other hand, instability stress fractures. So, for example, we have a bone called our navicular, and this guy typically doesn't touch the ground. So, when we talk about stress fractures, this is where if something isn't touching the ground, how are we getting too much load through that?
Hmm.
With instability, if those muscles, tendons, ligaments are pulling really hard on that bone because they don't have that control, that's where we can get those stress types reactions,
Hmm.
even at bones that aren't hitting the ground. And yeah, this is, well, after everything is healed,
Yeah.
stress wise, that rehab is going to look drastically different between these two types. And and yeah, taking the time to rehab after stress fractures
Hmm.
so important for building that run back.
Yeah, and I think, one thing that's coming to mind is how do these different types of stress fractures correlate with the different foot types that we talked about earlier?
Yeah, and so this is where if I have that higher arched foot, and I don't have that ability to shock absorb, and I'm landing really heavy on that heel, that
Hmm.
can predispose me a little bit for calcaneal type stress fractures. If I have a very flat foot without a ton of that control of the foot, and so that navicular, without getting too much into it, that posterior tibialis is a muscle that really helps guide that arch,
Hmm.
and it attaches onto that navicular. If that post tib is doing so much work and pulling really hard on the navicular,
Yeah,
at some point the navicular is going to say, "Oh my
had
gosh,
enough.
I can't do this anymore." And yeah, we'll get those stress type reactions there.
Totally. And like we're talking about, you guys, muscles pull on bones, right? Tendons attach to bones, they pull on them. That's how things move. And through that process, in a normal situation, when those muscles pull on the bones, that's what helps bones get stronger, right? Wolff's Law, we help cause some stress. The body responds to it by laying down more bone, getting stronger. But when that spectrum is like shifted too far one way, where the amount of load and the amount of tug that's happening on the bone is more than what the bone can handle. And sometimes there's other variables that go into this, like maybe we're not recovering properly enough, we're not getting enough sleep, we have a lot of stress going on in our life, we're not getting enough fueling and nutrition in, and we're not giving ourselves enough to repair with. These can often be factors, but when that stress on the bone is more than what it can handle, eventually it's going to fail, right? And we're going to have an injury take place to that bone, or what we call a stress fracture. And like we said, these are things we cannot run through because we can create ourselves a whole host of longer term problems where you may affect yourself for many years to come, if not the rest of your life, if you don't take care of this when the presentation is there. And this is maybe an overgeneralization, but basically what Emily just said is because of how people tend to land and where we absorb our shock in our foot, in the heel, on the outside of the foot, like what's contacting the ground first. When we have heel and outer foot stress fractures, those tend to be more due to that issue with shock absorption. When we have things that are more on the medial side, the inner side of the foot, near the arch, near the big toe, the part of the foot that touches the ground next, not initially, usually in most people's run, those tend to be due to a lack of stability because we're not controlling that process of rolling through the foot properly. And how we handle those is going to look a little bit different in the rehab phase.
Oh, definitely.
Yeah.
Yeah, and that's a again to emphasize, yes, heal the stress fracture, but consult with a medical professional afterwards because we don't want to keep running the same way
Hmm.
as we can have the same injury. And yeah, those stress fractures, that means a couple weeks off your feet without load.
Yeah.
So yeah, taking the time to work through those is so important.
Yeah. And how many times, Emily, have you had somebody like come in the office who has told you a story about how they have had repeated stress fractures? And many times that story probably is paired with the descriptors of like, I had a stress fracture, I took time off to let it heal, and then I just went right back to training. And then I had another stress fracture next year, and I had another stress fracture 6 months later. And like, you're just probably like pulling your hair out, like, oh my gosh, we can help you with this if we would have just met you a long time ago.
Yeah, yeah, and like you said, that's also something where we want to look at all the other variables of repeated stress fractures. We definitely want to be looking at protein and fueling and enough in the system to be able to repair those things.
Hmm.
So yeah, it's even bigger of a picture than we would ever consider.
Yeah, totally, totally. Well, man, I thought this was awesome. Diving into plantar fasciitis, shoes, Achilles, stress fractures. Before though, we start the process of kind of like winding this down and wrapping this up. Um, Based on the conversations that we have had, is there anything that you feel like we missed or that we went over a little too generally that you want to dive in a little deeper before we wind things down?
Yeah, so we had mentioned a little bit of foot strike, and so this is
Mm-hmm.
where we do have those two big camps of heel strike and then forefoot strike. Midfoot strike is the idea that they're both hitting at relatively the same time. And so that's where we kind of cut that difference. And, and there's huge debate about foot strike of you should only land on your heel, you should only land on your forefoot, you should only land midfoot.
Yeah.
And what I tell so many of my people is if I'm out on a run and I start to get a little knee pain, okay, let me see if I'm able to change up my foot strike a little bit to switch that load around. I'll use that for 30 to 60 seconds, and then I'll go back to my normal run and see if things feel better. If it does, awesome. Body just needed a second to recalibrate, refine that nice run gait, run pattern.
Mm-hmm.
And, and so this is where heel strike is going to be more load placed through knees and hips. Forefoot strike is going to be more load placed through foot and ankle. And so we can kind of play around with these things of where I strike and use that to our advantage and say, something doesn't feel right. Let me see if I'm able to just do a small switch and have things reset and have things feel better.
Interesting. Using how we strike our foot as that input changer, as an exercise in a way. And I think kind of what Emily's getting at is like what we know from what the research says, and I say this to clients all the time. I care way less about how your foot hits the ground compared to where your foot hits the ground. If we're doing a gait analysis on someone and we're filming them running, and we slow it down and look at what it looks like, no matter how your foot's hitting the ground, we don't want people striking way out in front of themselves, or what we call the center of mass, like where your body is. We don't want you striking way out in front, because then, that provides us or gives us a deceleration force in our running. And it's slowing us down, but two, it's giving us a lot more force reaction from the ground. We want people to strike close to underneath their body, right? So that we are propelling ourselves forward and not fighting gravity as we're having that little forward lean. But when we land with a heel strike, compared to landing with a forefoot strike, it doesn't change the percentage of runners that get injured. Runners still get injured at basically the same rate. But what Emily just said is so important. How we land changes what structures are being loaded the most. And when we land more on our heel, the knee, the shin, and other things up the chain get more of the stress. And when we land on the front of our foot, the calf, the Achilles gets more of the load. And we just tend to see a shift of percentages of where these injuries take place. Not that one person, one type of camp gets hurt more or less than the other. They all get hurt roughly the same amount, just where they tend to deal with these chronic problems is different, generally speaking. Um, so yeah, I think I've definitely been somebody who, from reading that, has let go of my belief that like I want people to run a certain way because, and knowing what you just said too, like we can use how people strike the ground as a tool in our tool belt.
Yeah, definitely. And it's a really easy tool to use.
Hmm. Yeah, I like that. Anything else you want to dive into on foot strike?
I don't think so. I think
Yeah,
that
I
was
think
a nice overview.
Yeah, I think that's good. And I think, I would encourage anybody that's listening to this. Many of us know how our foot hits the ground, right? Especially if you've been a runner for a long time, you kind of are familiar with your body. But if you don't, or if you're a newer runner and you're just sort of like unsure, I think doing a gait analysis with a professional like Emily, like myself, or someone in our offices that's skilled to do it, not just like having your friend film you or something that doesn't know exactly what's going on, just to get that awareness and to be able to see how your body's actually functioning and moving. I will tell you, it's really weird to watch yourself run when you watch your own video. It always looks different than what you picture it looking. We just watched the Olympics, and I think we all picture ourselves looking just like those folks, and most of us don't. But I think it's a great tool that we can use to learn a little bit more about ourselves.
Yeah, yeah. And I mean, like you mentioned, it always makes me laugh of I think everyone can see a runner and be like, something doesn't look right. But to
Yeah,
ourselves, we're like, no, I look
it looks
amazing.
great.
Everything
Yeah,
is beautiful. And like you mentioned, I've had someone film me and show me what I look like running, and I'm like, ooh, yeah, we still got some things to work on. We still got some
yeah.
things to work
Totally. I'm right there with you. Well, Emily, again, I really appreciate you carving out some time, hopping on here. I know we had to schedule this between you and I a ways out in the future to make it happen with our busy schedules, training and clients and everything. But I want to make sure that people know where they can find you, where they can get in contact with you and your team if they need to or want to. So what's the best way online that people are going to be able to do that?
Yeah, so Total Health Solutions is the clinic here in Lakewood. So through Instagram, that'll be THS Clinic, or online, that's totalhealthsolutions.com. Gait Happens is our virtual company, and so similarly on Instagram, that's Gait Happens, and then online, gatehappens.com. And lastly, my personal Instagram is Dr. Emily Schilling, if you're looking for a little bit more info.
Awesome. I'll be sure to include those things in the show notes and give you guys a recommendation. Our offices here for Physio Room, we tend to be a little bit more in the South Denver area, Highlands Ranch, DTC, about 30 minutes away from either one of those locations to the Total Health Solutions Clinic. And on more than one occasion, I have recommended to clients or significant others of clients or people that live in that part of town, like, hey, if you're going to be driving an hour to come see me and that's just inconvenient for you, we have some other places, including your guys' office, that we can recommend to you to make sure you can get a level of care that we are going to be happy with at another place that's going to be more convenient for people. Because if you live here in the Denver area, trying to traverse town during rush hour can be quite a daunting task. And if we can save you a little bit of time and make sure the quality of care you receive is not going to suffer, can't recommend these guys enough. So um, again, all of you guys that tuned in to listen to us on the code, talking all things about the foot, really appreciate your guys' time. And whether this was your first episode or whether you've been here for a lot of them to this point, really appreciate you tuning in. Reviews go a long way to help us get this show in front of more and more people. So if you've not already done so, man, I would really appreciate if you could scroll to the review section on whatever podcast platform you're choosing to listen on, drop 5 stars on there and share this episode with somebody else that you think this conversation could help out. And we hope to catch you guys on another episode of The Code. We'll see you later.